Next challenging debate would be led by Dr. Jayesh Vazirani. He's a daring surgeon with great forays into the most novel approaches in limbal stem cell transplantation and all its ramifications, into even managing the end-stage corneal disease. And he is going to tell us why keratoprosthesis is the way to go in bilateral limbal stem cell deficiency with wet eye. And he is going to be countered by none other than our dynamic moderator, Dr. Sayan Basu, who's going to dwell on the role of cell-based therapy for bilateral limbal stem cell deficiencies. So on to you, Dr. Jayesh.
Right. Thank you so much, ma'am. Is my screen visible?
Yeah, not your screen yet. Yes.
All right. Right. So I can sense the intensity of the debates going down progressively, and this might actually even be friendly because essentially both of us are on the same team. So the question posed here is, what is the optimum approach for bilateral limbal stem cell deficiency in wet eyes? And my answer to that, as with my answer to most questions in life, is it depends. What it depends on, let me just go through that. So we know now for certain that unilateral and bilateral limbal stem cell deficiency have very different causes. And if we look at this large cohort from India, we know that unilateral limbal stem cell deficiency essentially is most often, or in about 8 or 9 cases out of 10, due to ocular surface burns. And these are almost always wet eyes. Whereas bilateral LSCD may be due to other causes which are also equally significant, such as allergic keratoconjunctivitis, blistering skin diseases such as SJS, pemphigoid, etc. So based on that, the approach to unilateral and bilateral LSCD varies a lot. So whenever we see an opportunity to restore vision in a case of limbal stem cell deficiency, and this is something I've learned over the years from both Dr. San Basu as well as Dr. Sangwan, is to look at 3 or 4 things. One is, what is the underlying cause or process, disease process? Is it active or not? Is there any systemic therapy required to bring that disease under control? Is it a one-time insult, for say, for instance, a chemical injury versus an ongoing damage such as pemphigoid? And of course, whether the surface is wet or dry. So we had actually published the sort of algorithm that we use for approaching vision restoration in LSCD. And this is part of that algorithm that deals with the bilateral part. And then I'll further bring it down to the wet surface. So essentially, these are the options that we have for vision restoration. And although I'm going to speak on keratoprosthesis surgery, I'll interchangeably use the term Boston type 1 K-Pro. And when I'm talking about cell-based therapy, I would probably speak about SLET, because I believe these are the 2 most common and most time-tested and the best approaches that represent keratoprosthesis surgery and cell-based therapy, respectively. So the type 1 K-Pro is a collar stud device, and there have been multiple incremental improvements over the years to this design. This is the latest design. And there are some prerequisites that one needs to have before one does type 1 K-Pro surgery in an eye. I'll just point out that most important is the ability to maintain a bandage contact lens, because otherwise the K-Pro doesn't stay in the eye very long. Of course, it needs to be a wet surface and the underlying disease process needs to be controlled. There are also some exclusion criteria, and the most important is severe dry eye and diseases such as SJS and pemphigoid. So to me, what are the advantages of a K-Pro approach to eyes with bilateral LSCD with a wet ocular surface? The first one is that surgery is relatively straightforward. Anyone who does a penetrating keratoplasty doesn't need to learn too much extra while doing a keratoprosthesis surgery. It is repeatable if needed. If you do a K-Pro surgery, you don't need to give systemic immunosuppression. And this is very important in our context, because if you're doing cell-based approaches such as allo SLET, you need to put the patient on immunosuppression, and even the cheapest immunosuppression would entail a cost of at least 100 rupees per day, if not more. So this is very important for our patients. And also equally important is a lot of causes of LSCD have simultaneous stromal corneal opacification and sometimes also have cataract. So all of these can be taken care of simultaneously when you do a K-Pro. There are potential complications and these should not be played down. But over a period of time, with improvements in the design as well as the protocols for managing patients, these have come down, but they still exist. So if we compare the blindness-free survival curves after Capro surgery, that's the green curve, versus the cell-based approaches. And this is, of course, in a limited cohort of patients. You see that patients with Capro have better vision and they have a longer blindness-free retention of that vision, at least up to 5 years. So this was the data that we compiled in that paper that I just mentioned. So these are the key points that I look at while making a decision. So if you are going to do an allo sled, best is to have a living donor because results are better with living donors than cadavers. And I may be corrected if I'm wrong. So if you don't have a willing living donor, maybe a Capro is a better approach. If you're going to use cadaveric tissue, there are specific criteria that one needs to look at. The tissue needs to be fresh. It needs to have a good epithelium and limbus, and you need to probably use it within a few hours of harvesting it. So if that is not feasible, you don't have an in-house eye bank, then again, a Capro might be a better approach than an alloslate. If you have coexisting stromal opacity, I think it makes sense to do a Capro rather than doing a alloslit and then doing either a lamellar or a penetrating keratoplasty. If you have a cataract, well, this is not quite black and white. You could always do a slit and then do cataract surgery. But if a patient needs vision immediately, it's better to do a Capro. And of course, if the patient cannot afford immunosuppression or it's not feasible due to medical reasons to give immunosuppression, it's always better to do a Capro than to do an alloslit and have it fail due to lack of immunosuppression. So to conclude, keratoprosthesis surgery is a safe and effective means of immediate vision restoration in cases of bilateral limbal stem cell deficiency with wet ocular surfaces. And incremental improvements in both design and protocols have led to better outcomes and lower complication rates over the years. I believe it offers significant advantages in selected cases over allogenic cell-based therapy. But the choice of treatment modality needs to be customized as per the requirements of the eye and the patient. So as I said in the beginning, it depends.
Thank you, Dr. Jayesh. Those were very strong points.